Welcome back to Real Estate Mindset. Today's video is going to be absolutely bonker. We're going to talk about the problems with healthcare, the mass nurse layoffs that are happening around the nation, hospitals closing down, CVS, Walgreens, Rite Aid, all closing down. And today I have a special guest, Hannah, with us today, who is an industry ER expert that's going to try to help shed some light on all of the challenges that are happening with healthcare. Because quite frankly, Hannah, I don't know what to believe. On one hand, there's a shortage of people needed. And on the other hand, what the heck is with all the layoffs and hospitals closing? So before I begin, I think it's Thursday night. It's almost 8 o'clock because you are a night ER nurse. Is that right?
I am. Yep. I work night shift.
Well, how are you today?
Good. Just starting my day. So still bright-eyed and bushy-tailed. So ready to get started with this.
I'm ready. I'm on the opposite spectrum. I get up at about 2 to 3 a.m. Now, before I begin, Hannah, I'm going to get started by showing the viewers, in fast-paced format, exactly the challenges that are going on, not only with just the layoffs with nurses, but the systemic problems with the industry. Starting with layoffs, this is a Challenger report for September, and I just wanted to highlight healthcare for 2024 so far. Job losses of 41,794. Again, really surprising considering we're short-staffed. Now, in addition to that, another thing that I follow, Hannah, are the WARN notices. This is a notice system that employers are required to report to if they're going to do mass layoffs. And I keep seeing healthcare or nurse-related layoffs, and it's absolutely blowing my mind. And this is a lot of California. You see that right here, and you can see the date that they were issued. So this is this month. You see right here, here's Kaiser Permanente right here. I mean, huge clusters and blocks of these layoffs. Here's another one right here. This is Blue Shield of California as well. Look at, and this is the beginning of this month. Look at the end of September, right here as well. Cygnus Home Services, Kaiser Foundation Hospitals as well. I mean, this is absolutely crazy. And when I look at my own local market here in Houston, Texas, Hannah, Texas Children's Hospital losses soar. Essentially what this is saying is Texas Children's Hospital has been operating with a loss somehow of $354 million. So instead of them restructuring, completely just restructuring and changing the way their CEOs are paid bonuses, they just laid off 1,000 people instead.
Which that blows my mind, because that's not even sustainable. I mean, unfortunately, healthcare systems as a whole in America, they are a business. America runs healthcare as a business. And this, just even from a business standpoint, doesn't make sense. You're getting rid of the people that are there to help you make money. I don't understand the logic in that.
There's no logic. It's fraud, greed, and corruption. And we'll go into that here in a minute, but it's just like the same thing every single time. It's really depressing. But look at this. This article just came out. This is October 10th. This is all recent information. 21 hospitals closed so far in 2024. And look at some of this. This is Dallas-based Stewart Healthcare filed notices for closure on October 7th. Thomasville Regional Medical Center, Modesto, California-based Surgical Hospital as well. Hicksville, Ohio-based Community Memorial Hospital. Mercy One closed as well. Stewart closed. Boston-based hospital. Stewart also closed another hospital here. I mean, it just goes on. A regional health system closed their flagship Norman Regional Hospital. Columbus-based University of Missouri Healthcare Women's Hospital closed. Longview, Texas-based Select Specialty Hospital closed. Family Hospital closed. Hospital, Cedar Park, Texas. A lot of places in Texas as well. I mean, look at Regional Medical Center. I mean, it goes on and on. Port Arthur-based medical center, another medical center in Ohio. Here's another one in Omaha, Family Hospital. And this, again, Hannah, this is just for this year. Now, in addition to that, we got a lot of headlines this month, one of them being Walgreens planning to close 1,200 stores nationwide. And it goes into some reasons why. But in addition to that, this month, CVS Pharmacy plans to lay off, this just came out, by the way, 3,000 employees. And when you look at, the challenges, the reason why, challenges facing the healthcare system, corporate restructuring, right? Probably CEO bonuses, things like that. But in addition to that, remember Rite Aid too. This was in August, but there are now over 800 Rite Aid stores closing amid bankruptcy. I know that was a lot of information, but did anything I just show you stand out to you?
So working in the emergency room and seeing a lot of patients firsthand, the last thing I want to do is go home and, do the research that you have done. So seeing a lot of that information is news to me, but it's not very shocking, considering
Okay.
patients that I see that are coming in to, have a long-term treatment for something that they already have been diagnosed with, but they're not able to get their prescription filled. So seeing now we're laying off the people that work at the pharmacy, but now we're also closing doors to these pharmacies. That absolutely makes sense that I have a 70-year-old coming in for an antibiotic. That's crazy to me.
Yeah. And you know what? You hit the nail on the head. That's why I've been working to try to get you to do this interview for like 2 months, because I'm looking at the research, or your boots on the ground. Like you said, when you get home, you're not researching this stuff. And so can you start, Hannah, by telling the viewers what your background is, and then just start wherever you'd like as far as what challenges you're facing on a daily basis?
So what I will say is I will start back to, over a decade ago, I started off my healthcare career as a CNA, where I worked in long-term care, specifically Alzheimer's and dementia. And knowing then and hearing the struggles of the family members there of, just the cost of things, and just also the emotional tolls that it would take on them having a loved one in a facility like that. So I did that for a few years, and then I eventually worked my way into neonatal ICU, which was a great learning experience. And I have a lot of, positive things to say about that, working at an inpatient side of a hospital. I then transitioned my career to EMT, where I worked in the emergency room, and I've been doing that since 2018. I have been an EMT. And then in the last year and a half, I have started my career as a registered nurse that I've been working as, and have been doing that since then in the emergency room, mainly on night shift. And so seeing that and a lot more struggles from an outpatient perspective in an emergency room, it brings a whole different set of struggles that I see with patients and family, as well as with staff.
Okay. So in other words, you now work in the ER. The ER part per se of the ER part of the hospital has its own set of rules. And in essence, you can't turn people away. We'll get into that. But now that we've caught the viewers up, you have an extensive background in healthcare. You're now working for an ER. What is it about your job that you witness that needs to change? And while you're talking, please share some of your insights on why you might be seeing some of these layoffs.
So working in an emergency room, especially on night shift, my shift starts at 7 p.m. So that means when I get to work, it is most of the time some of the higher volumes of patients that we're seeing, including the amount of rescues that are coming in, ambulances bringing patients in as well. So with the way it's structured in an emergency room, which is different than inpatient, is we have multiple shifts throughout the day. So that way we have more staff coming on and then slowly leaving as the day progresses until about 3 o'clock in the morning, which is a good way to structure an emergency room, because it's so fluctuating that we don't know what's going to happen and when it's going to happen. And so I come in at 7 o'clock in the evening, I get my report on my patients, and they could be at all different steps in their treatment progress. They could be just getting there by ambulance, or they could be at a point where they're going to be going to the ICU in the next 10 minutes. So with that, it becomes a big struggle of prioritizing and managing my time to make sure I'm seeing who is the sickest, who is going to have the worst outcome if I don't see them now, which is something that a lot of patients, when they come into an emergency room, don't think about. They see the patient that, got here 5 minutes ago and is now going back to a room, even though they've been there for an hour. And it's based off of an acuity level, meaning if you're not dead, dying, then you're gonna sit there and wait, and you're gonna be happy that you have the ability to wait that hour and not have your life on the line if you're not seen that quickly. And I think that's something a lot of people don't think about. And so when I get those patients back there, I try to run through their history the best that I can. And in the area that I'm at, it is an older population that we see. So we do run into the issues of memory issues, or, family that's not nearby to help out with a lot of this history gathering, which is super important for a patient's care, because it can even be something as simple as an allergy to a medication that we might give, all the way to, they have a contraindication of to a medication based off of comorbidities that they have. And so, and I know this is a lot of information as well. And so we are lucky that we have additional staff on the floor that's able to help us out, ranging from EMTs to paramedics and sometimes CNAs to help us with the blood work and the EKGs and things like that. And so we're very happy to have that. And that information, I mean, it can flip on a dime. I could have a patient that comes in and they are under a Baker Act, which is a safety hold because they could be a harm to themselves or somebody else. It could be somebody as simple as making a statement that they said unintentionally to the wrong person. Or it could be something as far as an outburst at the grocery store and they are now brought in, and now we lose staff to hang out with that patient to make sure that the patient is safe. And then it puts everything else on the back burner as well.
And you're specifically speaking, about the ER and how important it is because it's an emergency to quickly decipher information to save people's lives. Probably Absolutely. The most important thing in healthcare that we have, emergency, help these people. And so it sounds like that you're a tight-knit crew. Everyone has a very vital duty, but when something kind of gets out of the norm, which is an emergency, it pulls that person, that very vital pillar, off of helping any other person. Is that right?
Yeah, so we have to direct our resources accordingly. So and this was something that stuck out to me when I had a resident that I worked with who was in the middle of their medical residency to become a doctor. And he was a phenomenal individual. He was a registered nurse prior, and he had talked with the patient to, do a research paper or something. And he asked the patient, I know you've been here in the waiting room for a long time. We're busy and you might not see that from the waiting room because it's on the other side of this wall, but we are very busy. Would your mind be changed if you saw that we were doing CPR on a patient in the waiting room? Would you then say, okay, you know what? I can hold off for a second. And that was something that stuck with me, that these patients in the waiting room, absolutely every single person is important. And I don't downplay anything that they are experiencing, but medicine, it's a science. It is, can you live another hour? We are doing minute by minute to figure out who needs help the fastest. And I think giving that perspective to the general public is something that they either don't have that perspective on or something they've never thought about. They're thinking about themselves. They're thinking about their pain and their emergency in their mind, that this is something important. So to be told, you're having an emergency, but this person is having a bigger emergency is not something that a lot of people in general can comprehend.
Would you say that the ER facility that you work in is big enough and has enough staff?
So I wish I could say that we are big enough and we have enough staff. And I think that's something that every hospital across the country is struggling with. And in an area that is growing as fastly as this area, we are seeing a huge influx of residents to the area, which in turn brings us more patients. And so we are a nonprofit hospital. And so we had our hospital built. And the day that we opened our hospital, we started expanding, because that was the realization of, oh my goodness, we are seeing, almost double what we thought we were going to see. And whether that was because it takes years to build a hospital and the original numbers just had changed, or if the original numbers were just wrong to begin with. I don't know, because of how quickly this area is developing.
Okay. And we talked a little bit before this. You said something to the effect that because it's a non-for-profit, yet the CEOs are getting bonuses and making $2 million. Okay. Is that not profit? I mean, what's he spending $2 million on? Does he have health issues that cost that much money? I'm not going to go there, but if he waived $1 million, he could build another 10,000 square foot facility, but let's not go there. So so the state basically directs you in one capacity or another. I believe they said you need to make a hospital that's built for 17,000 people, but the first year there was 40,000 people. That's more than double. Can you take the viewers through the process of Like, how would you get more help? Why aren't you getting more help? Why don't you have double the staff? Why aren't you opening another facility for the community? What's going on, and why can't you get more help?
So there are other hospitals in the area. The other hospitals in the area, they are for profit, which means they are about bringing that money in. So when patients have the option to go to this for-profit hospital where their care might kind of take a back seat versus going to a nonprofit hospital where honestly their feedback is what provides a lot of I don't know if it's monetary value that comes back for reimbursement sakes, but it is a big part of it. So I believe it might be a number close to 90% of patients that are seen will get something in the mail about how was your stay, and it'll ask them specific questions. And there's certain keywords that are mentioned that as nurses and staff we should be mentioning. To kind of trigger that in their minds, like, you're going to get a survey in the mail. I want to make sure you remember me saying these certain words, kind of thing. And so based off of those numbers, being a nonprofit, we need that insurance payout essentially to give us that.
Are you saying that from the best of your ability, we don't have to use any names, that for-profit hospitals have a worse service from your experience?
Yes, which is something I
That's
never
not possible.
was a thing. I know. And it was something that, being on the outside, I never thought of, but going through the schooling that I have had, clinical rotations where I'm at different hospitals across the state. And those for-profit hospitals, it blows my mind. And it's honestly kind of like a double-edged sword, being a nonprofit hospital where that's not our main priority. It's that patient care to get that reimbursement and get that money in that way. But it's also, we are nonprofit. So that means we can spend $1 million on this piece of equipment that would make this patient care even better. We can get that new CAT scan machine. We can get that new MRI because we're nonprofit. We can write that off, so we can have that top of the line equipment to better serve these patients in our community, which is amazing. Where these for-profit hospitals I've been at, they are pinching every penny they can,
not
whether
the CEOs.
Right. Unfortunately. And I don't know if they're just maintaining that lifestyle or if they're putting it all back into the community. I don't know, but I have a feeling.
Texas Children's Hospital, I believe, donated $100 million to a golf charity event in 2025. So I don't know. I don't think that's helping maybe it's helping the community. I think that the community, because I'm part of it, would prefer another 1,000 nurses to help with the quality of care.
Absolutely.
So, so you mentioned, I didn't even think of that. So one of the reasons why you've been crazy busy is because as a nonprofit, somehow the service is comparably exceptional. And I want to get into the hiring process. I want you to tell the viewers the whole chain of command and how bad that is. But share with the viewers what happened to the for-profit hospital that was down the street from where your current hospital is, and how that hospital, because oh my gosh, that closed. So Hannah had a hospital close literally right down the street from the hospital she works in now. Why did that hospital close, do you think? And was it for profit?
So that one was a for-profit hospital. That was a hospital. I stepped foot into the emergency room when I was newer to the area as a visitor. I wasn't a patient there. And just seeing the conditions and seeing the staff as well, just how overworked and stressed, they wore it on their face, and that was something that always bothered me, and just how much they were, how hard they were working to try to maintain and keep up with those things. Because most of the nurses that I work with, we're in this profession because we wanted to make a difference. We wanted to help, and to be that person and to be helpless blows my mind. So when I heard that they're closing a hospital when we are seeing such a high volume of patients, it blew my mind. And then I had to think, okay, well, why would they be closing a hospital? And what I then learned was that it was not in a good structural condition, as well, as far as the integrity of the building, I guess you could say, needed some work. More than I guess was doable. So it was just easier to close that hospital down. And the staff, I work with a lot of them now. We had that hospital closed down, so the staff had to go somewhere. And I'm very lucky to work with those people who have been in the worst kind of situation you can work in as a nurse. And just seeing how they thrived and turned around, and just hearing some of the stories that they had to say about it just blew my mind, as far as how a hospital can be run like that when a CEO is putting this much money in their pocket and not giving those resources back into the community.
Your boyfriend works for another hospital, and it's actually the same company, but different medical director. They fight for employees differently. Can you explain for him, not necessarily you, because I know it's worse for his hospital. Like, so if he came and he was like, hey, we need more people out here. He's in the emergency room as well. We got people's health in danger, possible people, I don't know, hopefully not, but potentially dying. How could he get help? If he wanted to ask, or even you needed to ask for help, how do you go about doing that?
So we have a certain level of chain of command. And so you did mention medical director. So the medical director is one of the doctors at the hospital who holds that title, who can dictate essentially your scope of practice, which is a great thing to have, because it can help differentiate between one job and the next job and holding a different set of skills within that same realm. So as far as our chain of command, in my role, I am a registered nurse. I have, and especially on night shift, I have a charge nurse who is the nurse on the same shift, who is in charge of the unit at the time. So if I have any issues in the meantime, as far as patient complaints or issues in the department, I would go to the charge nurse. They would help me out. We would get things squared away. If it is something that is out of their scope, we have a nursing supervisor who is on staff. And a lot of the nursing supervisors we have, one of them is actually a good friend that I worked with years ago at the hospital as well, who worked his way up. And so he would be somebody I would go to get additional resources to help out with those things. As far as getting staff in the doors, for my boyfriend at the hospital he works at, we work under the same healthcare system. We work at different hospital locations. So his location, he has his manager, who would be his next up. And then he has a director of the department who is the next up. And those two positions hold more of like banker's hours, 9 to 5, Monday through Friday kind of thing. So one of the issues when I worked at that hospital he's currently at was the turnover. You could hold 100 interviews in a month. You could hire 100 of those applicants. They were not there 3 months later. The turnover is what the issue is. We get people in the door. We get them hired, we get them trained. They're not happy, they leave.
Okay.
So the difference between that is the hospital I work at with my manager and my director, they are definitely, my manager, he is a huge advocate for our staff. He is always somebody I can go to if there's an issue, to see if there's any, he's always the first to see if he can help out with anything. He comes in early to make sure he sees the night shift staff. He's there late in the day to make sure he sees every employee that's there that day. He's a great guy to have around, to vouch for his staff. Unfortunately, that's not always enough, because he's not the end all be all. He has a boss who has a boss who has a boss. So he can bring these complaints up the ladder as much as he wants, but he doesn't have that final say so. But that is a big difference, is the staff that we hire, we could have 100 interviews. And we get to, it's crazy that I get to say that, we get to be selective with who we hire. We don't say, oh, you have a pulse, you have a license, you get to come to work. We can say, you might not be a good fit, which is a great thing to be able to do, because that retains the staff that's hired. We get to keep those nurses, we get to keep those techs on the floor. And that's not something every hospital gets to say. So we are a much better representation of retaining our staff based off of how we're treated. If we're not treated right, we wouldn't stay.
Yeah. And that's one of the things when we were talking earlier, that kind of hit me. You have the good hospital per se, or the hospital, like everyone, you told me people from out of state come because they want to work at your facility. So you have a pretty good facility. It sounds like you have it's a lot of chiefs, going up, but it sounds like it's a pretty effective, especially when you compare to your boyfriends. Is that right?
Yeah. Oh, absolutely.
So let me ask you this question then. If it's so effective, are you understaffed right now?
So in different capacities, yes, we are. As an emergency room, our patient volume can fluctuate hour by hour. And so we have a set number of nurses. So what they base this off of is it's called a matrix. So we look at the past month's volumes to say, okay, we have this many patients. That means we get this many nurses. Well, if only it were that simple, right? To say that last month's numbers are going to be the same as this month's numbers. But if I have, a drowning and a car accident that I didn't have last month, well, that's already more patient volume than what we anticipated. And so when we are short staffed, a lot of the times it's because of those things that we're not expecting, but also working night shift specifically. That's not everybody's cup of tea. I love it. I've been doing it for a long time. I love working night shift. Not everybody does. It's not conducive to a lot of people's lifestyle. So we have people that will leave night shift and go to day shift. And then that gap never gets filled. And then another person who wants to leave night shift and go to day shift, and we're not filling those spaces. So now we have that one additional patient that comes in that we weren't planning on, and that's pulling those resources to that patient.
Yeah.
And it definitely ruins the flow of those things.
And I'm not knocking you. What I've learned in doing all these investigations, Hannah, is when we look under the hood, it's a completely different story. It's really sad. It's really shocking a lot of times as well. And I've lost a lot of sleep over it because on the front end, when we work with good people, like the person you were mentioning, we have the premise and this assumption, and usually it's a false assumption that they're working with us, they're trying their best. But I just showed you 40-some thousand layoffs. I showed you the hospital closed right down the street. Where are those people at? Why aren't they working here? So as much as you love them, someone's in the way I'm looking at it, just for math. I'm just looking for math. It's not for profit. What the hell? You should always have too much staff than not enough, especially when it comes to emergencies. Can you go into, when you have these moments of being understaffed and because you've been doing this for a while, and whether it's maybe you've heard about it, maybe it's not under your watch, but is there never a situation to where these ERs get so busy because they're understaffed and there's maybe an influx of emergencies to where you could see a situation to where their health care would be negatively impacted?
Absolutely. And this is something that I think about daily when I go into work. So I haven't seen it. I have heard stories of people that have seen it, and I can definitely see it happening for sure, where in the waiting room, we could have, we're a smaller hospital. So for us to have 20 patients in our waiting room, that's a lot of patients. And most of the time, especially on night shift, we have one nurse in triage. So that one nurse is getting those patients in, essentially, lining them up, getting their basic information. This is a triage. This is to say, are you dying or can you wait a minute? This is where we can start the process of getting that blood work, getting EKGs, getting chest x-rays, doing those things to at least get something moving along for them. And so when those patients come in, we get that information, they go back out to the waiting room, and that's where they're going to sit until x-ray pulls them or until we get them back to an exam room in the department where they can be seen by a physician. I have had countless patients in this area that are, 80 plus years old, and they go into the waiting room when I'm done seeing them. And now I have a new line coming in. So I can't reassess that patient for a minute. I can't get another set of vitals. This is, a patient with COPD whose oxygen levels are fine right now, but can I know that they're gonna maintain that? I can't guarantee that. So now it's, do I bring that patient that I just saw after an hour? Do I bring them back to me and take another set of look at them? Or do I get that patient that I haven't laid eyes on yet to see if they're having an emergency? So it's a lot of weighing and balancing, and it's pulling a lot of people very thin to make that decision of, should I check on this patient who I've already seen, or do I see this patient I haven't seen yet and hope that they're not going to die in the next 10 minutes?
And in the case of Texas Children's Hospital, what does any of that have to do with a golf tournament?
Unless these people are bringing in the, money, Mr. Moneybags, and they're saying, I'm going to donate all of this millions of dollars to the hospital, I can't see where else that money would make a difference.
Let's move on to something that, I think a root cause of this, because clearly we want doctors, we want nurses, we want too many of them. So and there's a need for that. There's more people older and older and older. So to me, it brings me back to the same thing. Healthcare is unaffordable. And I believe that's why we're seeing, that healthcare system with the insurance fraud and all that, in conjunction with these crazy CEO bonuses and the lack of proper business practices, that all is combined. But with, CVS closing down, Walgreens, Rite Aid, I think that's more of a systemic healthcare thing. Can you tell the viewers, what you've seen, boots on the ground, with problems with insurance? Can you talk about that man you were telling me about, his wife? And can you go tell us that story?
So as far as that systemic issue, that brings me back to another topic that I'm going to address in a second. But I had a patient the other day. She was a very sweet woman who was diagnosed with Alzheimer's, and her husband, wanted to keep her at home. He was a little bit younger and healthier, so he wanted to keep her at home as long as he could. He referred to her as his best friend, and that kind of melted my heart. And so when he eventually, after 4 years, decided he had to put her in a facility where she could get, more attention, since he was, out and about, and he did also still work. He wanted her to be in a place where she was safe, had medical staff, and also was surrounded by more people like her, where she could sit there and play cards, for hours on end and not have a stress in the world. And I was in there going over some education and some information with him about her care. And he opened up to me and was talking to me about how he has 2 different forms of insurance for her. And he is still paying $7,000 out of pocket a month for his wife to have that medical care.
So he has 2 forms of insurance. It costs $7,000 in addition to those. There's your cat back there.
Yeah, that's funny. One of them.
Yeah. One of the 3, so it's like, these people, they pay their dues their whole life. They pay into the medical, there's this whole, false sense of you're going to be okay, live happily ever after. But this poor man is just trying to take care of his wife. She doesn't even remember him. He's paying everything, his life savings. He has multiple insurance.
Yep.
It's insane,
Sold their house to, downgrade and get something smaller so he can start paying for these bills. Yeah, it's one of the saddest, most gut-wrenching things I've seen, is somebody who is here to help people. And to hear that is what these companies can do, hiding behind a mask, and they're making these decisions of people's lives and deciding what they should and should not be able to do.
I wonder if they're doing that when they're playing golf. Do you think?
I think that's the last thing they're thinking about, is how this man and his wife are coping with things and struggling financially to pay these bills and to pay them on time. I don't think they're not losing any sleep over that.
And maybe they should make a golf tournament on his behalf, and they should take those proceeds and help this man out. I want to move on. We're about 30 some minutes in. You're doing great. Thank you, Hannah, so much. Can you tell the viewers, just boots on the ground? It's nothing. It doesn't really need to be. I know you haven't done enough research on this to talk about it confidently. Okay, so there is some speculation, but I think we have the right person speculating per se. Talk about GoodRx. Talk about the insurance situation. This is what I found out real quick. It cost me. I have to have a procedure done, 2 procedures done every year. It costs me less money out of my pocket if I don't have insurance. And I'm not counting the $1,000 premium I pay so I pay $1,000 a month. I'm not counting that. I'm just saying my out of pocket is cheaper with no insurance. When I found that out, really upset me.
Yeah.
So I'm paying, because I'm wasting $12,000 and I'm paying more money for the procedure.
Absolutely.
Why is that going on?
So why it's going on, like you said in the beginning, it's greed. It is absolute greed, and people wanting more than what they should have. And so part of it, and working where I have, and talking with people I've talked to, one of my own little conspiracy theories, if you will, is insurance companies owning GoodRx would absolutely make sense, because we're paying that insurance company, we're paying them a lot of money, especially for specific prescription premiums. And so to be able to go onto a website like GoodRx, where we're getting a great deal, by not using what we're paying for with our insurance, and we're going to pay GoodRx as we're paying for out of pocket for these, that's troubling, because if there's a will, there's a way. If I'm able to go on GoodRx and I'm able to get my medication for $10, but if I get it with my insurance company and I'm paying even $50, well, why? Where is my money going? Is it just to keep that insurance staff and that CEO? Is it just to, put more money in their pockets? Because if that's the case, they can start losing some of their staff to help, the patients.
I'm about to pull up the golf tournament on you. Okay. I'm gonna pull it up on you, but I want you to talk to the viewers about, do you think that these pharmaceutical companies have some type of backdoor agreement with GoodRx?
I feel like they would have to. I can't think of a scenario where they don't, because and especially pharmaceutical, everybody knows big pharma, so they hold a lot of power. So if big pharma came to a smaller, insurance company and said, hey, I'm going to give you X amount of dollars, for each of these prescriptions, and you're in a good populated area, for let's say lisinopril, a blood pressure medication. And if you're in that area where a lot of people are on this blood pressure medication, and you're going to get paid, $5 off the top for every prescription you fill through this insurance company, how many people aren't going to take them up on that offer?
There it is. Sorry,
I didn't know.
You're doing good. Well,
No,
that's why it's so expensive. It's Texas Showing Houston Open. Whoa, it's a 6-day event. Look at that. So this is a PGA Tour. Look at that top sponsor. Look, they put more money than Chevron, BP, Oxy, Conoco, Quanta. And again, I can't help but think that is absolutely disgusting and tacky when they just laid off 1,000 people. Again, like you're telling the viewers here, impacting the quality care of people that are spending their life savings to get care. Go ahead.
So I was going to add to another thing too, as far as healthcare being a business. With every business does come liability, So if I have a patient who comes in because their stomach hurts, well, more than likely, they ate that bad pizza that they shouldn't have, and that's why it hurts. But because of that issue with liability, if that patient walks out and develops something bigger, they could then sue the hospital. So we refer to something in the hospital called $1 million workup, because that's essentially what that is. You can come in and say, I drank too much alcohol and I started vomiting, and now my rib hurts because of all the vomiting. Well, you're going to get blood work. You're going to get a urine sample. We're probably going to do a chest x-ray. And when that comes back fine, because again, it's something that could be simply explained, we're probably going to send you over for a CAT scan as well, because of that issue with liability after the fact. And a lot of these doctors that I work with as well, I talk to them about a patient to let them know what's going on before they can get in there. And they say, oh, it's probably this. They're medical professionals. They're trained. They have experience and the knowledge. And I would trust the doctors that I work with my life. Absolutely. So when they say, oh, it's probably this, something simple, well, you're getting that whole workup anyway, because we have to make sure, because we don't want you to sue us, And so that's an issue that I see a lot of the times, is when patients do finally come in and they're getting this big workup. A lot of the times I get asked, well, why do I need this done? Well, why are they doing that? Because even in the deep, the patient knows that it's probably something not that serious. But that's the other issue we run into, is a lot of them are saying, oh, my primary care doctor told me to come here, because they're so backed up in their primary care offices with all of these patients that they don't have any other solution than to send them to an emergency room, where we're going to do this full, most of the time, unnecessary workup, where the insurance is getting charged, the hospital is end up paying out of pocket, the patient pays even more. And it's a lose-lose situation at a systemic level.
Not for the pharmaceutical companies and the CEOs, which brings me back to this. And you may not know about this, but I've heard, I think this was on a podcast from a doctor, a pharmaceutical company, that said that he's under a gag order if he didn't have that gag order, he can tell us how to get prescriptions for significantly cheaper, and it would actually be much more profitable for him. So very efficient, right? But he's like, because of a gag order, I can't tell you that. And now you have to pay more money for prescriptions and I make less money. Are you familiar with such a gag order?
So I have heard stories of such where as soon as a pharmacy knows that insurance is involved, on the patient's end, that they can no longer talk about private pay options, which, it blows my mind that that's even a thing. How about do what's best for the patient and that situation? And, that also brings me to another point where it is kind of a double-edged sword being in America where healthcare is run as a business, because we have that option to have a lot of privately funded research that goes on for, the new cancer drug or the new diabetic medication and those kinds of things. So where I say it's a double-edged sword is because we have the ability to do those and to do that research. And unfortunately, and fortunately, I guess, because it does get put under a patent for, X amount of time, sometimes 10 years, which is why a lot of those medication prices will then drop after that time frame, because that money has now been put back into big pharma to recoup the cost of the research they did. So that's where I say it's nice that we're able to be able to do that research, knowing it's not a lost cause as far as a business perspective, knowing that that money will be recouped in one way or another. And without that, what's the incentive to research and do more do more studies into that medicine, but at what cost, you know?
So let's just, I know you said you love conspiracy theories, but do you think, I think the answer is yes, but there's a but. Do you think that there is a cure for cancer?
Yes.
As do I.
And I only say that, so I've never worked with cancer patients in an oncology perspective, only cancer patients that have come to the emergency room for something unrelated. I do work with people who have worked as oncology nurses who have told me, I had a patient that came in with this diagnosis. We did this treatment. It didn't work, and they had passed because of it. And then he says, I also had a different patient, a Mr. Moneybags patient, who had the same diagnosis, who had a different treatment plan, and who had a better outcome. So of course, I'm going to be skeptical, if you will, as to, well, why didn't we do it this way? Why was this course of action chosen instead? So I try to remain firm in my science ground, if you will. But then I have those little, loose nuts and bolts where I say, well, coincidence, is that correlation? I don't know.
And yet you work for a nonprofit. It's funny how, the only thing I don't understand about the nonprofit is the non part. Everything else I understand.
Oh, well, I'm not profiting. So there's the non. I'm the non.
Oh, yeah, you're the non. Everyone above you is the profit. Yeah,
right.
That makes well said, Hannah. Let's end this out. You've been talking for a long time. I really appreciate all of your insights and how late it is for you to do this. If you could, with all your experience, the challenges you saw, can you dig deep in? Can you tell us what would you like to change? What is the one thing, most important thing you would like to see changed in the healthcare system?
So I think a big part of it is having more available physicians. I mean, it wasn't something I thought of wholeheartedly until you just asked me that. I think it's something where we need accountability, but not to the point where we are treating patients unnecessarily for things that they may or may not have, because I might have a hunch that I've seen this once. That blows my mind. So patients and their ability to sue a doctor is honestly, I mean, it has a lot of negative repercussions. And I think if we were able to have a standard of care and just as a society have everybody on the same page of, as medical professionals, we are here to help you. I don't go to work thinking, how can I mess somebody's life up? I'm there to do everything that I can to make sure you are taken care of, to make sure your family is taken care of as well. And I think if we could get society on the same page of, if I have an emergency, let me go to an emergency room so we're not backlogging everything else. And if I have something that's urgent but not emergent, let me go to an urgent care where I can be seen in a timely manner and get this issue resolved. But I think it comes down to, I don't think healthcare should be free. I think healthcare should be affordable. I think I should not have to pay $500 for a Tylenol when I go to a hospital. That is what I believe. I believe I shouldn't have to pay an exorbitant amount of money for something that's already paid for to line the pockets of somebody that I'm never going to meet. I think it should be affordable.
You know what? I just, when I was hearing you, Hannah, it was a little bit heartbreaking because, part of me would argue that society is already on the same page. The workers, the people that want healthcare, we all have this preconceived notion and assumption that we have a great healthcare system. And if we go to the hospital, we're going to be okay unless you're in the hospital, unless you're in the medical system. And then you start to, oh, wait a minute, maybe this healthcare system is not, not that good. And I would also argue that there are, even for me, I had a PPO my whole life. I had a PPO. I've recently canceled it because I learned that unlike what society thinks, the affordability is out of the system. No, I don't have like $100,000 in care I need a year, right? Mm-hmm. So, I'm hearing you, but like, don't you, let me ask you this last question. How much do you think the entire systemic issue would be fixed if we just corrected human greed? How much do you think it really stems from that one thing, the greed?
I would say 98%.
And yet you didn't mention that. Why?
So greed, I think, is a very big part of it. And it kind of comes back to that double-edged sword where these CEOs making, I think the hospital you mentioned, Texas Children, I think her income was upwards of over $7 million. Which I can't understand what somebody is doing with that at all. That just blows my mind. Like, I'm over here, scraping by, working and helping these people out. And I'm just trying to think, what would I do with even half of that, a quarter of that, a tenth of that? What would I do with that?
Yeah.
And so with the greed itself, there's absolutely greed. And the only reason I don't say 100% of it would be solved if greed wasn't a factor is because when that patient does come in with a heart attack or a stroke or a bad car accident where their leg is cut off, that's a lot of resources. We're going to have at least one doctor, an emergency room doctor in that room. We're going to have a trauma surgeon in that room. We're going to have at least 3 nurses. We're going to have at least 2 techs. If the patient's coding and we need CPR, we're going to add 2 additional techs to that room. We're going to have the pharmacist at the bedside. We're pulling all of these resources into one room, which if you just looked at the hourly rate, for myself as someone who's not a big wig, Mr. Moneybags, just the rate alone of what it would pay to keep those people in that room is a lot of money. And then you add the medical equipment and the testing, and then you do a CAT scan, and now you have to have that radiologist interpret it, which is a doctor who went to medical school to read these scans. Now you have their hourly rate. So if we were all coming out, as a clean, open cut across the board, we didn't make more, we didn't make less, we cut, broke even on that.
Yes.
It would still be expensive. So does it need to be this expensive? Absolutely not.
Right. Yeah. I mean, I agree with you. Maybe if there's a little bit less golf, we can do a little bit more care.
Yes.
Now I'm gonna let you go. I appreciate it. I don't think I'm gonna be able to get this out tonight. It's already 8:30, but I definitely appreciate you. And to the viewers, comment below. Let us know what you thought of what Hannah was saying, whether or not you agree. I was tired of looking at all these articles. I wanted to get someone that's been in the medical field, very honest, very good person that's doing it because she wants to help people. That's your legacy. And I know that because I know you. So I'm going to get you guys out of here. We look forward to hearing from your comments. And other than that, if you guys are out there just living your life, trying to live, we wish you luck and we hope you win.